for cancer treatment. So these are some questions that as a clinician treating this patient, I ask myself, and potentially you would be asking yourself as well. And these questions help to sort of stimulate the rest of the talk today and provide a framework for the rest of the talk. So is there a role for surveillance imaging beyond the cancer treatment? If so, which modality should be used, and which parameter should we be following? Should we be following EF or some other parameter? What is her actual risk of developing heart failure down the road? She had LV dysfunction, but what is her risk of heart failure? And is she at risk for other cardiac events down the road? Are there effective prevention strategies? Should we be keeping her on the ACE inhibitor and beta blocker indefinitely? Are there potentially non-pharmacotherapy treatments that are reasonable? And so today I'm going to provide just an overview really for the role of cardiac MRI in patients with heart failure, highlighting a little bit of the work that we've done, looking at diagnosis and surveillance of heart failure, and then looking at some interesting work we've done with lung water quantification in patients with or at risk for heart failure. And then I'd like to talk about how we've used MRI to offer some insights into understanding the latent risk of cardiovascular disease in cancer survivors. So MRI is increasingly available in Canada, especially cardiac MRI. And I just spent a couple minutes talking about in Edmonton what we have. So we have a 1.5 Tesla. We actually have the exact same magnet that you guys have in here for your clinical program. We do approximately 1,500 scans a year, and that's, I think, a comparable number to what you guys are doing from what I understand. And then our patient referral group, so largely we're scanning patients with cardiomyopathy, non-ischemic or ischemic, diseases of the aorta, and congenital heart disease. This is our big referral group. And then we also have a 3T research magnet as well that's run by our biomedical engineering group. And they do cardiac research as well as brain research. And then, MRI, the reason why it is a popular imaging modality is just like echo, it's very safe. And in fact, there's recent data suggesting that even groups that are traditionally not considered safe for MRI are actually safe to scan. So we've been scanning patients with implantable electronic devices, as well as there's also now a lot of data showing that giving gadolinium contrast to patients with end-stage renal disease is also safe, that the risk of NSF with the newer contrast agents is actually very low. MRI offers very detailed information on cardiac structure and function, and you can also use it to characterize myocardial tissue, which are very important features of heart failure. And in fact, the CCS, the last heart failure guidelines, to my knowledge, to talk about the role of imaging in heart failure were the 2017 heart failure guidelines. And they recommend echocardiography for the initial evaluation of cardiac function. However, cardiac MRI does have a 2A recommendation to assess LVEF and volume for patients with heart failure. And MRI really, by many, is considered the gold standard for evaluating biventricular size and function. And it's also, in my view, ideally suited to evaluate serial changes in EF because it has excellent inter-observer reproducibility. And then the same 2017 heart failure guidelines recommend cardiac imaging to assess myocardial viability in patients with heart failure and coronary artery disease. And these are two examples of patients with myocardial infarction using a technique called Lategadolinium Enhancement to characterize infarction. And in this example, you'll see infarcted myocardium appears as white, and viable myocardium appears as dark. And so on the left, we have a 3-chamber view depicting a mid-LAD distribution subendocardial infarction. On the right, we have a 2-chamber view depicting a transmural LAD territory myocardial infarction. And in fact, the degree of transmurality has been shown to predict recovery of cardiac function viability in patients undergoing revascularization. This study showed that if you had 10 or more viable segments defined as a transmurality less than 50%, showed that you would improve your cardiac function at least 3% with bypass surgery. And then the same 2017 heart failure guidelines also recommend using cardiac MRI to evaluate for myocardial scar or infiltration. And probably the way now that we're assessing infiltration and inflammation is using something called T1 mapping. This was something, one of the earliest studies was in 2008, where this investigator Isles showed that T1 quantification correlated with myocardial fibrosis on histological examination. T1 mapping has also been used to derive extracellular volume fraction, as well as diagnosed infiltrative heart disease. This is an example of a study we've used in Fabry disease. You can see that on the left of this figure, we have healthy control patients which had normal T1 values which were higher than we saw in Fabry disease. Here in the middle column, you can see they had lower T1 values. And then on the right, we had hypertensive heart disease patients, which often resemble Fabry's, because Fabry's is an infiltrative disease, so they have thickening of the myocardium. But in hypertensive heart disease, they also had elevated T1. So T1 quantification was very good at differentiating these three groups of patients. And then T1 mapping is commonly used to evaluate for amyloidosis, as well as myocarditis. And Eric Shelbert in the US has shown in at-risk patients for heart failure, if T1 mapping does predict incident heart failure down the road. So if you do T1 mapping on patients and follow them over time, the ones with higher T1 values, many of them go on to develop heart failure. Okay. We also do something called T2 quantification, which is a measure of myocardial edema. It's often used as a surrogate measure for myocardial edema. These values are commonly used to assess for the presence of myocarditis. And this is a figure from a study which showed in patients with dilated cardiomyopathy, you could detect signs of active myocarditis using T2. So this patient had elevated global T2 of the heart of 68 milliseconds. Normal would be less than 59. And so you can look for myocardial inflammation in patients with dilated cardiomyopathy. A T2 has also been used to characterize acute infarct, and as well as area at risk from acute infarct. And then we've used T2 values as well to look for a transplant rejection. It correlates well with histological evidence for transplant rejection. So at this point, you know, I've said MRI has a lot of use in patients with heart failure and non-ischemic heart failure in particular. So why don't we just do MRI in every patient that we suspect with non-ischemic heart failure? Well, we tried to answer this question with the IMAGE heart failure study, which Rob, as you all know, led. And in this case, the Outsmart heart failure study was a randomized controlled trial, multi-center, and we hypothesized that routine cardiac MRI would yield more specific diagnoses of heart failure than selective use, which is the use that we're doing now. We're using it selectively. And so we randomized 500 patients from 10 sites to either routine MRI versus selective MRI in patients with non-ischemic heart failure. And in the selective group, the predominant imaging modality to try to diagnose the heart failure was echocardiography. And somewhat to my surprise anyway, we found that routine cardiac MRI did not increase the rate of specific heart failure diagnoses. And in fact, on this figure here, there seems to be a very slight trend in having more specific heart failure diagnosis from the selective use arm. So our study supports the current recommendation of only using MRI selectively for non-ischemic heart failure. It must be said, though, that infiltrative and inflammatory cardiomyopathies only comprised about 10% of our population of our study. And this is a group where I still think MRI should be studied as having a potential role for helping and make the diagnosis. Okay, and finally, the 2017 heart failure guidelines recommend that routine assessment of LV function should not be performed, stating that there is a lack of clinical benefit. Even though it's a commonly used technique, do you guys do often serial assessments of LV function in heart failure patients? Stable? Yes, I'm being told yes. We do as well. And perhaps this is why you're doing it. In fact, in the same heart failure document, there's a figure that says you could consider doing LVEF reassessment every 1 to 5 years in stable heart failure patients with reduced ejection fraction. And part of the justification for doing it, in my mind, is there is echo data actually from Alberta, a fellow named Finley McAllister, who I work with in the heart function clinic. He showed that patients who have recovered EF tend to have better prognoses than patients who do not have recovered EF. So there's potentially a rationale for checking their ejection fraction. But again, there's no, there's not a lot of evidence and not a lot of MRI evidence that I'm aware of following patients serially with heart failure. So we in fact did a study in Alberta called the Alberta Heart Study, which was really meant to be a prospective cohort study to understand the pathophysiology of heart failure with preserved ejection fraction. But we also had patients at risk for heart failure in that study, and we had patients with reduced heart failure and reduced ejection fraction. And we did MRI at baseline in 1 year in most of the patients in that study. So what we decided to do was we looked at the data and said, this was data gathered from Edmonton and Calgary, and we hypothesized that there is likely a CMR parameter over 1 year that can be used to help predict outcomes for these patients. So, we looked at the change in CMR parameters at 1 year. And so in this case, we examined 262 patients that we had 1 year data. Okay, so after adjusting for clinical parameters, which included the MAGIC score, we also adjusted for serum BNP. We found the only CMR parameter, 1 year change in CMR parameter that helped and provide incremental value to predicting risk in our patients was LV mass, actually. So this was across the entire cohort, which included HFrEF, HFpEF at-risk patients. When we only looked at the HFrEF patients, LV mass was still the only parameter, a change in LV mass that predicted outcome. And then this cubic spline model shows really an exponential relationship between a change in LV mass and your risk for developing cardiovascular events down the road. So you can see, and we found actually the threshold for predicting risk was really greater than 15%. So if you had, so the take-home message from this study is if you had a greater than 15% change in your LV mass at 1 year, that was a threshold that predicted risk for your heart failure patients. And when I thought about it, LV mass kind of makes sense because volume is susceptible to loading conditions from one day to the next. It could depend on your dose of diuretic. And EF is also a little bit more susceptible to loading conditions. Mass is a more sturdy measure. It takes a lot to change the mass of a heart. So intuitively, it kind of made sense to me when I thought about it afterwards. Okay, now we're going to review some data that we have from a study, a very, in my view, interesting study we did on lung water quantification in heart failure. And this was really enabled by my collaborator in biomedical engineering, Richard Thompson. We had a discussion, can we develop MRI to image the lungs while we're doing these cardiac scans on patients to quantify the amount of pulmonary edema that they have. And so he developed a very simple, a 3 to 5 minute non-breath hold scan that we could add to the MRI while the patients are being scanned to complement all of the other myocardial information that we're getting. And so this is an example where you see on the left is a healthy control. On the right is a patient, and you can see that the patient is lying on their back. They have a lot of pulmonary edema, and you can see that even in the dependent zones at the back, there's even higher amounts of lung water compared to the anterior zones of the lung. We also found in a small number of patients that were with heart failure going for cath, we did an MRI on them immediately after the cath, and we found quite a decent correlation between the amount of lung water and filling pressures. And we also found a good correlation with BNP in the same patients. And then so we decided to add the lung water sequence to virtually all of the patients in Edmonton anyway in the Alberta Heart Study. So we had data on 256 patients in the Alberta Heart Study. So we have data from healthy controls at the top of this figure. We have at-risk patients below, and then we have different types of heart failure patients. And you can see from the healthy control data, we established that normal lung water was anything less than 20.8%. So if you had less than 20.8%, you were potentially in the normal or healthy region. Anything more than 20.8% would be considered abnormal. And in fact, 26% of the patients in either heart failure or at risk had abnormal or wet lungs defined by our normal threshold. So these were ambulatory heart failure patients. These were patients, coming from home to get a scan. And then we then looked at the outcomes for the patients in the Alberta Heart Study, and we found that patients with wet lungs, so patients with above this threshold, so the 26% that were above this threshold, this was independently predictive on multivariate analysis of cardiac events. And this is a Kaplan-Meier curve showing that if you had wet lungs in red, you had much more events over 1 year than patients with dry lungs. So it seemed like a powerful independent predictor. So after this study, we applied, Dr. Thompson and I, and got funding from CIHR, and we're now evaluating changes in lung water in patients admitted with acute heart failure, seeing how much the treatments that we give patients make an impact on lung water, and seeing if the change in lung water also predicts subsequent outcomes. So that's something we're evaluating right now. So the summary of my first part of my talk is that cardiac MRI is used to assess LV function at baseline and often used for follow-up assessments in patients with heart failure or cardiomyopathy. And we have data that suggests that LV mass is also, a change in LV mass is also a potentially useful parameter to monitor in patients with heart failure. And then MRI is often used, and I'm sure you guys are using it here, to assess for infiltrative disease, in particular cardiac amyloid, as well as inflammatory disease such as myocarditis. Takotsubo as well would be useful. And then MRI is also used to assess viability, and Rob tells me we're going to learn something more soon from image 1A, which is evaluating MRI amongst other imaging modality techniques to assess viability in patients with ischemic heart failure. And then lung water is an emerging metric, which I think can be used in heart failure, but it can also be used in many other cardiac diseases as a potentially important prognostic measure. Okay, now for the last part of my talk, I'm going to review some MRI data that we have that we are trying to better understand what is the cardiovascular risk in cancer survivors. And just so you know, you may know this already, cardiovascular disease is highly prevalent in patients with cancer. And so this was a large US healthcare database study of over 200,000 patients. And they found that patients with cancer had CVD prevalence of 27% compared to 17% for cancer-free controls. And in terms of heart failure, the prevalence was about 4 to 12%. compared to general population, the rate of heart failure would usually be around 1%. And the rates of coronary artery disease and peripheral arterial disease were even higher than for heart failure. So there's a very heavy burden of cardiovascular disease in patients with cancer. And you can even see some cancer types have very high cardiovascular disease burden, hematologic malignancies, lung cancer, GU cancers as well. So on a background, there's already a lot of cardiovascular disease in patients with cancer. Additionally, the cancer treatment itself would place patients at higher risk for incident cardiovascular disease. And this is a study that people from my group published in 2007, which proposed something called the multiple hit hypothesis. And so they theorized that cancer patients at baseline have, many of them have subclinical cardiovascular disease, and they then go on to receive treatments which directly injure the myocardium or the vasculature, or both in some cases. And then during the treatment, during cancer treatment, patients are often sedentary. They're not eating the same diet that they normally do. So there are some indirect effects of the treatment as well that places the patients at higher cardiovascular risk. And so what all of this translates into is a higher downstream risk of overt cardiovascular disease for many of these patients. And then I'll briefly review two common treatments that are given that cause cardiotoxicity, so that can affect myocardial function and ultimately increase the rate of cardiovascular morbidity and mortality. So anthracycline is a treatment, one of the oldest chemotherapy treatment that's used to treat breast cancer and lymphomas. And heart failure has been described in up to 5% of patients receiving this treatment. And cardiotoxicity is thought to arise from the inhibition of topoisomerase II, and that results in the activation of cell death pathways and release of troponin. So when we give people anticycline, you can actually detect troponin in the blood after they get anticycline. And patients are at higher lifetime risk for heart failure if they've received a cumulative dose of anticycline exceeding 250 milligrams per square meter. And then earlier in the presentation, I mentioned Trastuzumab, which is a monoclonal antibody against ERBB transmembrane receptor. It's a receptor that's largely used to regulate function in the heart and other organs. And this receptor gets overexpressed in about 25% of breast cancer, and it's a high risk marker for metastatic disease. Patients with overexpressing this receptor in their breast cancer have a higher potential for adverse prognosis and metastatic disease. So they developed a monoclonal antibody to treat this, Trastuzumab, and that's markedly improved breast cancer survival for these patients. But they realized that up to 25% of patients receiving this treatment do develop left ventricular dysfunction, like the echo example I showed you earlier. And about anywhere from 1 to 5% of these patients develop heart failure. So, given anthracycline and Trastuzumab that breast cancer patients are receiving these treatments, what is their actual risk, though, of developing heart failure in real world? This is some data from Ontario, which Dinesh Thavandir Nathan in Toronto published 6 years ago now. And he showed that patients receiving these treatments had approximately a 3-time greater risk of developing heart failure or cardiomyopathy if you followed them out to 5 years, okay, compared to patients who are not receiving these treatments. And one of the interesting things that I found is that even patients receiving other chemotherapy, so non-cardiotoxic chemotherapy, they actually had quite a high cardiovascular death event rate, higher than the so-called cardiotoxic regimen. So even the safe treatment may not be so safe. So we actually designed and performed a small RCT to try to answer the question, will giving prophylactic ACE inhibitors and beta blockers in patients with early breast cancer receiving Trastuzumab, will it help prevent declines in cardiac function? Will it help prevent remodeling that we see in patients receiving trastuzumab? And so this was an MRI-based study where we did MRI at baseline, 3 months, 12 months, and we randomized patients receiving trastuzumab to one of 3 groups, either placebo, ACE inhibitor, or a beta blocker. And we measured serial changes in left ventricular end diastolic volume, as well as serial changes in EF, to see if any of the treatments helped mitigate some of the effects of this treatment. And these are the main results of the study. We found that beta blockers and ACE inhibitors did not prevent remodeling, which was our primary outcome in the study, but it did prevent a decline in EF. So in the placebo group, there was on average a 5% decline in EF at 1 year. In the prindopril group, there was a 3% decline, and in the bisoprolol group, there was a 1%, only a 1% on average decline. And the other interesting thing is when people have a decline in ejection fraction, it often leads to an interruption of their treatment, and in some cases, a complete discontinuation of their breast cancer treatment. And there were fewer interruptions in treatment for people that were on prophylactic ACE inhibitors or beta blocker, and we had no patients that needed to come off of these treatments during the study. It was very safe. So, you know, we found that bisoprolol and prindopril prevent trastuzumab-mediated cardiac dysfunction. Other groups, however, have not had the same results. They haven't studied the same it hasn't been exactly the same patient population. It was largely anthracycline-based treatment, and they used other beta blockers. One used metoprolol, another used carvedilol, but nevertheless, so there is conflicting data out there. Despite that, you know, we published in 2016 recommendations saying that in high-risk patients receiving the trastuzumab or anticycline, you could consider a prophylactic ACE inhibitor or a beta blocker. So because of this conflicting data, it's led at least one person in the cardio-oncology community to question, is there a role for cardioprotection? You know, and part of that is, listen, we have conflicting data where it doesn't really necessarily show benefit, and on top of it, with newer chemo regimens, the prevalence of left ventricular dysfunction is actually quite low now, the incidence of left ventricular dysfunction. And then, so he published this article entitled Quo Vadis, and I had no idea what this meant. I'd never learned Latin before, but Quo Vadis, apparently it was a famous saying that was uttered from Christ to St. Peter after Christ was resurrected. He was walking on the road going back to Rome, and St. Peter saw him and said to him, Quo Vadis, where are you going, Christ? And he said, well, I'm heading back to Rome. Where are you going, Peter? And Peter was busy fleeing, so Peter suddenly rethought what he was doing, and he turned around and went back to Rome along with Christ. He ended up getting crucified himself, but anyway. So just like Quo Vadis, you know, myself and other people working in the cardio-oncology sphere, I think we're beginning to rethink some of our outcomes. So one of the things we did was I collaborated with a health outcomes researcher, Marcello Tonelli, who's actually a nephrologist in Calgary, and he does a lot of health outcomes research. And we decided to look at, you know, what is the actual, looking at the province of Alberta, what is the actual risk of cancer survivors developing heart failure, but also developing other cardiovascular disease, MI, stroke. So we wanted to get sort of a global view of what is the risk for these patients. And this study actually just came out a couple weeks ago in JACC Cardio-Oncology. And so what we did was we had an existing database comprising all of the residents of Alberta over 2007 to 2018. And we linked that database with the Alberta Cancer Registry to understand how many of the patients in the province of, how many people in the province of Alberta developed a new diagnosis of cancer. And then we also had data on all of their cardiovascular and non-cardiovascular comorbidities as well as their laboratory results. And so this is the table showing the number of patients. So, pretty impressive number, much higher than the MRI studies I'm used to doing, where we have 100 patients. So we had 200,000 patients with cancer, 4.3 million patients without cancer. You can see that, not surprisingly, the no cancer group was younger, had less cardiovascular comorbidities, which isn't surprising based on some of the earlier data that I showed you guys. And so we had about 12 years of follow-up on this cohort, and what we found was that there were a lot of cardiovascular events. So in the cancer group, there was a CV mortality rate of 2.3% versus 1.7% in the no cancer group, and really all cardiovascular event rates were higher, with the exception of MI. So MI rates seem to be similar. And so we decided to adjust for age, sex, socioeconomic factors, cardiovascular risk factors. And what we found after doing these adjustments is that the rates of cardiovascular mortality, stroke, heart failure, pulmonary embolism, and even MI was higher in the cancer group when you followed these patients. But then when we did a secondary analysis matching age and sex, the risk of MI was no longer significant. But the risk of all-cause mortality, cardiovascular mortality, stroke, heart failure, pulmonary embolism was all higher in the cancer group. So the cancer group is at risk for many different types of cardiovascular event, not just heart failure. Okay, so that's the take-home message. We're focused on heart failure in this group, but they're at risk for many cardiovascular events. And this is a figure showing the risk over time, how it changes. So you can see that the risk for these events is highest in the first year, but the risk of stroke goes all the way out to 7 years, and the risk of heart failure goes all the way out to 10 years, as does the risk for pulmonary embolism. So this is a sustained risk for these patients. Okay, so we found that a new cancer diagnosis does confer a higher risk of incident cardiovascular disease, even after adjusting for baseline risk, and the risk really extends over a long period of time. So we didn't have data on treatment, unfortunately, on cancer treatment, so that limited our modeling to some extent. But some of the questions that we ask, are there some risk factors that we weren't accounting for in our modeling, like physical activity, diet, body composition, and then maybe cancer itself also can influence cardiovascular risk. And there's actually some data, we have some data showing that patients with cancer, even before they get any treatment, have thicker hearts than normal. And other people have shown strain abnormalities in patients before they get any cancer treatment. So the heart may be abnormal to begin with in these patients. And so we did a secondary analysis of our Manticore trial, which was the trial that I showed you earlier with the 94 patients where we randomized people to ACE inhibitors, beta blockers, or placebo. And luckily, one of the person in our group had the foresight to say, you know what, in addition to looking at the heart, we should be also measuring body composition in these patients. And so we did some imaging of the abdomen using axial tissue composition imaging centered around the L3 vertebrae. And these are some examples of what we found. So these are two different patients. You can see on the top panel, there's a patient who has body weight loss during the treatment, but has concurrent muscle loss, which is the orange and red in the figure. So skeletal muscle mass went down for this patient, and visceral fat increased. So visceral fat is green, okay? So green, visceral fat bad, increased. Even though the overall weight, if you were just looking at overall weight, it went down, visceral fat actually increased for this patient. And this second example is of a patient who gained weight during the study and also had concurrent visceral fat gain, okay? And so across the whole 94 patient cohort, we found that there was significant loss of skeletal muscle volume during treatment, as well as increase in ectopic fat pools. And along with this, we measured serum biomarkers, and one of the markers we measured is IGF-1, which is an interesting measure that is in my view, cardiometabolic measure, which has been linked to risk of cardiovascular disease as well as to risk of cancer, actually. And many of the patients you can see here had a significant drop in IGF-1, and low IGF-1 is predictive of future cardiovascular disease. So these patients seem to have adverse changes to their cardiometabolic profile during their treatment. And in fact, and I'm not an expert on this, but I'm learning about it, and probably Peter Liu and other people can talk about this in greater detail, but ectopic fat is recognized to play an important role in metabolic syndrome. And in this diagram, you can see that patients getting energy-dense, rich foods and lack of physical activity contribute to a positive energy balance. And under some conditions like smoking or cancer treatment, that can lead to ectopic fat accumulation, and that in turn puts people at higher risk for developing metabolic syndrome or diabetes down the road. And that's what this figure on the right is showing, that if you have accumulation of visceral fat, it increases your risk for developing diabetes. So again, this might explain why some cancer survivors are developing or more prone to develop cardiovascular disease down the road. And in fact, there is CT data showing that if you have higher visceral fat at baseline before you get any cancer treatment, those in the highest tercile of visceral fat, they have the highest risk of developing cardiovascular disease down the road. Okay, so it is a risk marker for breast cancer, patients with breast cancer, for developing latent cardiovascular disease. So in summary, incident cardiovascular disease, including heart failure, is common in patients during and post-cancer. And we've shown that there are abnormal changes occurring to the cardiometabolic phenotype during cancer treatment. And we do need more studies to understand the pathogenesis of cardiovascular disease in patients post-cancer. What are the contributions of the treatment? What is the contributions potentially of the tumor itself? And host, are there some lifestyle changes that we can be recommending to these patients so that they're not accumulating visceral fat? So what direction are we going now, or at least in my program? So I can tell you about some of the things that I'm working or interested in. So we actually just completed a study evaluating the effects of cardiac rehab in patients with breast cancer, looking at if potential mitigating effects on a drop in LV function, as well as what are the effects on body composition. So this is a study we recently finished. And then we also are trying to elucidate some novel mechanisms of cancer-related cardiotoxicity. And I'm working with two basic scientists at the U of A on this. And then I mentioned earlier, we are using lung water imaging sequencing to study acute heart failure and what are some of the changes occurring during acute heart failure. And then we've recently completed a study looking at the effects, the whole body effects of COVID-19 on people. So we did brain imaging, heart imaging, lung imaging, abdominal imaging, skeletal muscle imaging, and we did functional tests, we did cognitive testing, 6-minute walks. So we want to understand what is the level of disability in patients after their COVID-19 illness, and are there any correlative findings on the MRI, And so with that, I'd like to acknowledge a number of people at the U of A who have helped me do these projects. I have collaborators in cardiology, oncology, basic science, and then I have more recently I've collaborated with people in population health studies. And I thank you, and I'd be happy to welcome any questions.
Thank you, Dr. Paterson, for that fabulous talk. So, forgot about the clap thing. Anyway, multiple ways to ask questions. You can either raise your hand and I'll pick you out, or you can raise your hand in the audience. So I see somebody's hand up, but I don't know who it is. Peter Liu's hand up. Peter.
There's a question.
Yeah, let me see. Is the mic working?
Yep, we hear you.
Oh, great. Yeah, thanks so much. And I put a comment also in the message that this is really a fantastic talk, where you really take advantage of the different tools available and, particularly imaging and trying to understand disease processes and also treatment options, so this is a really great illustration. And many of your findings, in fact, confirm some of the models that we have. Just a kind of put a little interesting twist to your last topic on the cardio-oncology aspect, and that is that we've been trying to explore this area to see, what is the intersection between the cardiovascular risk, as you well illustrated, and the cancer risk, right? So apart just from some of the risk factors, which we have actually dissected out nicely. And one of the thinking at the present time that we're also exploring is so-called the CHIP hypothesis, that is the clonal hematopoietic sort of expansion. And this is as you get older, you can actually get these mutations in the bone marrow in mainly actually in the inflammatory cells, and that then you have a more pro-inflammatory milieu, which then can be aggravated, both in inducing cancer as well as atherosclerosis, and that's why that joint aspect. And so I was fascinated by your study in terms of body composition, because it really actually shows that there is actually very much activation, of that system. So I was curious, I see the IGF-1, which is fascinating because we study IGF-1, IGF-BP7, sort of interaction, and whether there are other inflammatory markers you found in the population, that may suggest that this could be active, so some of the inflammatory processes that may actually, predispose the individuals to cancer, but also may drive some of these changes, especially once they're going on treatment, etc. So just curious on that fascinating finding.
Yeah, thanks, Peter. I mean, so this is all for me anyway. I'm going up a new learning curve here. I'm into cancer and now trying to understand metabolic syndrome and inflammatory pathways. So so the short answer to your question is I haven't measured a lot of other inflammatory markers in these patients. We were mainly focused, on cardiotoxicity. So we were focused on measuring changes in cardiac function and troponin and BNP and matrix remodeling proteins. So I wasn't thinking about looking at what's going on outside the heart. It's only when we went back to look at the data that I realized this is what was happening. So I do have blood, Peter, left on these patients. So if you have some ideas about some biomarkers I should be measuring. IGF-1, the reason I measured IGF-1 actually is because it is one peptide that's been shown to be linked to remodeling of the heart. And I was looking at it from that standpoint, not knowing that in fact it maybe was reflecting more inflammatory milieu, like you're saying. So I'm learning as I go here.
Yeah, I look forward to collaboration. Thank you. A fantastic talk.
Dr. Beanlands.
I don't know if you're going to have to repeat the question.
Yeah, I will.
First, I had a similar question to Peter, which was very elegantly described by Peter, but essentially the idea being, could it be that the patients actually are already predisposed to cardiovascular risk and cancer risk together, which is kind of, Peter talked about it from the biological side. So maybe if you have quick thoughts on
Sure.
that. And then my second question is, was the lung water, you said it was independent, was it independent of BNP?
Yes.
And if it is valuable, has it been able to change treatment or is that a next step to change treatment that might affect outcome?
So to repeat the two questions, actually I'll let Dr. Paterson repeat the two questions.
So the first question that Dr. Beelan's asked was, maybe the patients with cancer just are at baseline, they're already susceptible to both cardiovascular and cancer risk, and the answer is yes. So if we go back to the multiple hit hypothesis, at baseline, absolutely, these patients have elevated risk factor rates for cardiovascular disease. However, the treatment itself probably exacerbates that risk, as does some of the lifestyle changes that go on while people are getting this treatment. So they're more sedentary. We have some data that I didn't show you that shows that a lot of patients with cancer will access the dietitian, for example, at the Cancer Institute, and they are consistently recommended to eat energy-rich foods. So they're sedentary, eating energy-rich foods to maintain their weight, and they're getting cardiotoxic treatment. So you're setting them up for exacerbating this already poor milieu of cardiovascular disease. So I think, yes, at baseline, there's some inherent risk that increases and exacerbates during the treatment for a number of reasons. Now, your second question was about, does lung water provide incremental risk prediction over and above BNP? And the answer is yes, it does. And then the second part of your question was, can it lead to potentially a change in therapy or help guide therapy for these patients? So that part we're still trying to answer. So in the study we're doing in acute heart failure right now, we're trying to measure, how much does diuretic and other treatment actually affect changes in lung water. So we're measuring patients from the time that they are admitted, and then again repeating it at the time of discharge. And so we want to know, does the discharge, what's important here? Is it the admission lung water, the change in lung water, the discharge lung water? Do any of these parameters predict subsequent heart failure outcomes? And how effective are the treatments that we're giving on affecting changes on these? So absolutely. And I have ideas for other populations of patients where I think this could be valuable. One example would be a valvular heart disease to help guide who should be getting interventions on their valve.
Very fascinating.
Yeah, so that would be another idea for a project.
I think Gary Small has had a...
Yeah. Gary?
Can you hear me okay?
Yes, you're coming from the heavens here.
So great talk, Ian. I enjoyed that. Thank you. I had a question really about you touched on results from Manticore and hinted that perhaps T1 might be a predictor of kind of development of long-term heart failure. I just wondered if you'd looked at that, in your patients who, whether LV was preserved at the end of therapy, whether or not their T1 values was predictive of future events.
Yeah, so that's an excellent question. So we did measure T1 in our Manticore study. Keep in mind, we only have 94 patients, so it'll be hard for us to look at predicting heart failure, which is an event rate of anywhere from 1 to 3 to 5%. So nevertheless, we did find T1 values increased during the treatment early on, and then normalized by the time the 1 year came around. And that increase, transient increase in T1 also correlated with some other measures that suggested that there was some myocardial inflammation going on. So Trastuzumab seems to cause sort of transient myocardial inflammation based on this T1 measure that goes up and then normalizes. So actually at 1 year, the T1 value was similar to what it was at baseline. So we weren't able to actually find in this cohort a change in T1. This being said, other groups have studied anthracycline and shown that in patients who have prior anthracycline exposure, there were increases in T1. And so I think it's an important question, Gary, that, what is the significance of this increase in T1? Because, there is that data out there and a population level showing that increased T1 predicts a heart failure risk. So, and in terms of, do we have strategies to lower elevated T1 in people? That's another interesting question. I have some thoughts about that, but nothing proven so far.
Ian?
Dr. Baruch? Yeah, thanks a lot, Ian. A lot of the, what you're looking at, these measurements by MRI, we can kind of get by echo as well. LV mass measurements, we can kind of get a measurement there. Lung water, we can measure filling pressures by echo. Do you have an idea of how like MRI compares with echo? Like, do you have echoes in the same population? And is the MRI additive to what you can get from echo, or?
So in our Alberta heart study, we did have echo data at the same time as the MRI, so baseline in 1 year. So in the heart failure, in the breast cancer population, we don't. In the acute heart failure study we're doing, we actually are going to do ultrasound assessment of pulmonary edema as well. So I don't know if you guys are doing that here, but looking for those comet tails that people describe in acute heart failure. And then we're doing chest x-ray, because chest x-ray is still the gold standard. So we're comparing it to that. In terms of measurements or assessments of filling pressures, we didn't have that. We had BNP, but yeah, that would be an interesting study to try to look at filling pressures from echo, certainly in the acute heart failure study, seeing how that correlates. Many of the patients will have an echo when they come in with acute heart failure, so that could be something we build into the study. Yeah.
Have you done subgroup analysis in the lung water volume population based on age? Because clinically, patients that are young, less than 30, tend not to have as much pulmonary edema. Certainly the pediatric population, they tend not to get pulmonary edema clinically when they have failure. So I'm just curious if you have that. I've looked at that.
We did. So the question is, did we look at effect of age on lung water quantification in heart failure? We did look at it. There didn't appear to be any way in our group. These were patients with heart failure, so they weren't young. They were not young patients. So they were patients. I can't remember the mean age, but the mean age would have been in the early 60s. So we would not have had the younger adult population in that cohort, but in the cohort that we had, there didn't appear to be any relationship with age and lung water.
Okay, so probably just didn't have that population there.
We didn't have young adults with heart failure or congenital heart disease.
Well, I think we're almost out of time here. Here's a question in the chat from Dr. Ghosh. Dr. Ghosh is one of our community cardiologists who does some wonderful heart failure care as well, and also does some MRI reading as well. Have you assessed epicardial adiposity tissue and myocardial adiposity and incremental risk in cancer patients?
Yeah, that's an excellent question. We did not. We could though. We did. The reason we chose to do abdominal imaging is actually there's quite a lot of work now showing that. So we acquired 6 to 8 slices of abdominal axial imaging, and there's data now showing that what you find on the axial imaging actually is a good representation of what's going on in the whole body. So people have done studies showing that. So that's why we chose that slice. But you're right, epicardial fat also has been correlated with cardiovascular risk, and that's something that we could also evaluate in these patients.
So if there's no more questions, I just wanted to thank the IT folks, because this was our first hybrid rounds and it seems to have worked seamlessly. So thanks to Andrew Brown and his wonderful team. Also thanks to Dr. Paterson for a really very fascinating talk. Dr. Paterson's around for the rest of the morning. If anybody wants to meet with him this morning, just contact my office and we can fix that up for you. So now another virtual and real round of applause.
Yeah.